Thank you. Thank you for the introduction. And thank you, all of you, for welcoming to South Korea. It's been a wonderful few days. Professor Yu invited me here to listen to what you already have done here in South Korea on shared decision-making. And it's my pleasure today to give you some ideas about shared decision-making, from theory to skills. Where shall I start? Well, I'm going to start by telling you just a little bit about me. Some of you here were here on Monday, but not all of you. So I'm going to do a short introduction. I, first of all, before doing medicine, studied literature in Wales. You could check your map. It's a small country. It would fit into a small district in Seoul, actually. It's about 3 million people. And here you have 10 million people living already. After that, I did medicine in Cardiff, down at the south of Wales. And then I did my medical education, a master's, and then PhD. I have worked in Africa and in Netherlands, and about 10 years ago, I went to the United States to work in Dartmouth College. In fact, the president of Dartmouth College was Professor Kim, who came from South Korea before he went to the World Bank. So you may know that name. He was president of Dartmouth College after being in Harvard. I have worked with different universities, and I have also worked with industry because I like to try and make sure that things get into practice so that we take them from theory and put them into clinical practice. Some of you know maybe about the Oxford textbook of shared decision-making, which I edited with my colleagues Adrian Edwards and Natalie Joseph-Williams. Now, I often use this cartoon, and I ask the audience, what is this man saying? And I say to the audience, this is a medical visit, right? So this man and this woman are in a medical visit. And I ask the audience, what is he saying? And I ask for responses. And most audiences say that, oh, the man is saying, I have bad news for you, or these are your results of your investigations, or what brings you here today? How can I help you? In other words, most people think that this is the clinician speaking. And then I show the next slide, and I say, this is not the clinician speaking. This is the patient speaking. So the vast majority of audiences make the assumption that the man speaking is the clinician, is the health professional. But that's not the case. And then I ask a much more difficult question, which is, what did this woman do, the clinician, what did she do to help this man say those 4 words? Now, I'm not going to ask you to answer that question today, but I'm going to suggest she did a few things. She probably gave him some information that he could read. It was not a lot of information. It was brief, and it was in a way that he could understand it. But it was very accurate information. It was evidence-based. It was based on science. She also must have asked him a question, right? She must have just asked him a question to say, what do you prefer? And then she did a very important thing. She went silent. She paused. She waited. And when you examine medical visits and how people are speaking together, this is a very rare event where a clinician asks the patients, what do you prefer? And goes quiet. This is mostly because shared decision-making doesn't happen very often in most visits. This is not a common situation. And it's not a common situation for clinicians to ask such a question and to go silent. And I then say to the audience, if I only had 2 slides to explain what shared decision-making is, these would be the 2 slides. It's all I need. Because if you, in your clinical practice, whether it's whether it's physiotherapy, occupational therapy, nursing, doctors, if you can achieve this, that the person who comes to you for advice is able to say, thank you for giving me this information, I prefer this, you have achieved shared decision-making. That's it. But there's a few things that you have to do, right? There's a few skills you have to learn and a few things you have to do. Now, one of the things that really worries clinicians, doctors, nurses, anybody, is making a misdiagnosis, right? You make the wrong diagnosis. If you make the wrong diagnosis, everybody has a problem. The doctors feel guilty, the clinician is angry, the patient is angry, and the lawyers are around the corner. So it's a really big problem. But I'm going to suggest to you that we make misdiagnoses more often than we think. Let me show you. I'm going to tell you the story of Isabel. Isabel isn't very happy. She has heavy menstrual bleeding because she has uterine fibroids. And she's struggling, really struggling. She is 42. She's divorced. She has 1 child. And she is not happy about her sex life. So she's miserable. She goes to see the clinicians, right? In her mind, having talked to her friends, she thinks that hysterectomy is the only real effective treatment to take away the uterus. Her preference, however, has not been diagnosed. She has a talk with the clinician, and the decision is, let's proceed with a hysterectomy. She has a hysterectomy, and the recovery process is a bit complicated. It doesn't go very well. As a result, she has psychological challenges. And she also realizes, of course, that her chances of having a child in the future have gone. No more. No more chances. What if? What if is a counterfactual, imagining a different future. What if the situation had gone differently? What if the clinician had said to her, what's important to you, Isabel? And she would have said, you know, what's important to me is that I want the confidence to enjoy a new relationship. I've been divorced for a few years, and I would really like to have a new relationship. Maybe I would like another child. I only have 1 child. So this is in the back of Isabel's mind. But she doesn't feel like she can share it very easily. It's a bit private, right? It's a bit private. And unless somebody is asking her, she won't tell. So what if the clinician had asked her what's important and then had given her a tool to say, you know, you have a fibroid, but we have a few different ways of dealing with a fibroid. We could offer you radio frequency ablation just to shrink it down a little bit. We could do a myomectomy just to take that muscle lump away. It's not cancer, it's just a muscle lump. We could take it away. It's specialized surgery, but we can do it. Or, of course, we could do a hysterectomy. It's possible. But the uterine artery embolation, you stop the blood flow, or the ablation, or the myomectomy, will preserve your uterus. It is possible for you to have a child in the future. Or at least, it's possible to try. So, what's happened here? I think what's happened is that the clinician has done shared decision-making. He's asked what's important to her, Isabel, and now she has a new belief. She has more understanding. Her preference is to explore new relationships, maybe consider pregnancy. Together they decide, I'm going to try the myomectomy, not the hysterectomy. The experience is positive. She recovers well, and she joins Hinge. Do you have Hinge here? It's an online dating system. So she goes online and tries to find a new partner. She's not pregnant yet, but at least she has hope for the future. She has hope. What happened there was a preference misdiagnosis. And I think it happens a lot. So shared decision-making is about avoiding a preference misdiagnosis, where you don't check with people what's really important to them, right? If you don't check, then you are likely to offer them the wrong treatment. And I think that this is a big issue, especially nowadays, because people are going to the internet and finding out more information than ever before. It used to be that you could go to Google and you would have a few pages of places you could look and read. But now you can ask a large language model to say, give me the treatment options for uterine fibroids, and it will do a pretty good job. And it will tell you about the harms and the benefits. So when Isabel goes to the clinician, she's already been on Claude or OpenAI, and she already has a very good idea. So in the future, Isabel will not be happy if you do not tell her about her treatment choices. And I know South Korea is technologically advanced. You have advanced so quickly as a society that your patients will be wanting something like this. It's not only true in South Korea, it's true all over the world. Even in societies where there's a lot of respect for clinicians and hierarchy, this will begin to happen. So my question is, as you go to your practice, as you go to see your clinicians, you may want to think about how many preference misdiagnoses you might be making. Think about that. Okay. So some of you who were here on Monday, I'm going to just repeat a little bit because there are new people here. I think shared decision-making is not that complicated, really. It's just about bringing good science, evidence-based medicine, together with the experience of clinicians, be they nurses or doctors or other people, bringing those two things together, and as well, really making sure you know your people's preferences. It's not that complicated, but it takes a bit of time to do that well, right? It just takes a bit of time. So let me go through the steps which I think are important. I'm not going to go into a lot of detail, but there's the definition. And I do think this needs the professional to invite the patient to this process. Patients don't ask for this, not yet. They may well do in the future, but they don't ask for it yet. So there needs to be an invitation. And most patients now will say, oh, I'm not sure. I'm not used to this. I don't feel certain about the responsibility of making a decision. I feel uncomfortable. I would like you to make a decision for me. That's what most patients will say. So you have to support them in this process. They've not experienced it before, so they need support. And the other vital thing is if the patient says to me, I don't feel comfortable now making a decision. I am not going to abandon them to make a decision on their own. I'm going to help. But first of all, I want to give them some information so that they know what's involved. I want them to know the harms and the benefits of multiple options if those options are reasonable. And in Isabel's case, those options were more than reasonable. They were very good options, right? It was really important for her to know about the different procedures for fibroids. And the other thing, which I've heard here in South Korea loud and clear, is that the family matters. People will want to talk to their family, their partner, their friends, and their family. And they will want their input into the decision. So what does that mean? Well, it means that we can't make a decision in a single visit. We have to support people maybe over more than one visit. So we need a system that allows people time to understand what the choices are and to revisit those choices after they've talked to their family, right? And so a healthcare system that forces people to work very quickly in a short time space, it doesn't match the process. Doesn't match the process. So that's a system issue that we have to think about very carefully. How can we do this if we expect clinicians to work in very tight, short visits with no chance for a second discussion? It's not just a problem for South Korea, I promise you. It's a problem all over the world, right? Problem all over the world, where health systems pay for quantity, go fast, versus quality. What I'm talking about here is really high quality, where people are informed and they're involved and they feel, I made a fantastic decision. Even though I know something might not go right, I made a good decision. So, to make a good decision, we need to go back to goals. What was Isabel's goal? Maybe to have a second child. That was really important for her. So if the clinician doesn't know that, they are likely to make a big error. So shared decision-making really depends on finding out people's goals, both at the symptom level, I have heavy bleeding, functional level, heavy bleeding means I really can't have sex much because it's so awful, my bleeding. But the fundamental goal is more important. I want a child in the future. So the last bit, trustworthy information. It's where this field has been for the last 20 years. We've concentrated so much on patient decision aids, of making them making sure they are balanced, making sure they have a good science. And all that is very important. But I think we've neglected, Professor Yu, the communication between people, this process. It's not all about the decision aid. It's about communication between clinicians and patients. So this process, I think, as I mentioned, takes a little bit of time, takes a little bit of learning, takes a bit of attitude change. Attitude change. Somebody was saying to me, you know, I think the most important thing is an attitude change. And then the last step, having heard these information, and you talk about, shall we take the tooth out or shall we put in an implant, right? Now that you've heard the pros and the cons, what do you think? What do you want? What seems to fit with your life? And budget. Okay, so the deliberation piece is important. And what most patients say is, oh, thank you for giving me the information. I now need a bit of time to think about it. Let me come back to you. So have we designed a system that allows people to think about it carefully, essentially? Dr. Yu, Professor Yu asked me to say, talk a bit about teaching this to people. I'm happy to do that. I use this diagram to help teach people, the 3-talk model, because I can only remember 3 things, right, at any given time. So it's all about team talk, that asking about your goals, letting you know that I'm inviting you to a decision. All that is very important. It frames the conversation, the big frame around it. Because the next step is option talk, where I give you information, good information about the choices. And the last step is, let's hear your views and your preferences. Do you have any more questions? So in Texas, after I've been teaching some people in the masters in Dartmouth, they put this poster on the wall and said to all their doctors, hey, try this process. They didn't really teach them. They said, just try this. And one of the doctors said to the director of the clinic, hey, I already do this. And the director said, oh, good, great, fantastic. And then he asked a key question to this young doctor. He said, do your patients know you're doing it? And the young doctor said, I don't think so. So I said, why don't you try telling your patients that you're doing it? So a young doctor went away, and a couple of weeks later came back and said, I tried that. I tried telling my patients that I am doing this. And do you know what? They liked it. They really liked it. And I'm getting a better result in my visits. So I was already doing it, more or less, I think. But by telling my patients, being explicit about it, things went better. Interesting. And all the other doctors in the emergency department. This is an emergency department where things go quickly, right? Things go quickly there, and it's urgent. Things are going better for them. And this director is being asked in different emergency departments around the US to, hey, we heard you're doing good things in Texas, come talk to us. All right. I just found this paper 2 days ago because Professor Yu said, hey, how do we measure the teaching? So this paper just came out on 3rd of March, a few days ago. And let me show you what they did. They had an asynchronous online module, which means that people go online and read about shared decision-making. Then they had a 1-hour lecture on patient decision aids. And then they had a 2-hour interactive workshop, something like this. But they talked together, they interacted. And they measured whether or not the clinicians improved. So let's see the results. So they invited 61 pediatricians to be involved. It's interesting, only 21 took part, right? Not all of them were interested. So about a third of them were interested. That's normal. People are busy. But the scores on the option 5 measure jumped by 10 from 37, which is pretty low. Hisung will know this. They jumped to 47, so a 10-point jump. And they were happy with that. Now, this is only just a cross-sectional single study, but there are more of these kinds of studies. So it is possible to teach this skill. It can be taught. And the most effective ways of teaching are like this. You can give a lecture, but that's not very effective. This is probably the least effective way of teaching, right? Giving a lecture, really. Role play in workshops where you give people a role and they try it out and then they give feedback to them is really quite effective. Instruction with regular meetings, like they did in Texas, reasonably effective. But instruction with feedback, especially if you videotape and ask people to watch their videotape, now you're beginning to really change behavior. I don't know if anybody here has watched themselves on video. It's painful, right? It's really painful. So, is that me? Is that how I speak? Really? So, instruction, videotape, role play, and feedback, and watching your own video and say, oh, I think I will try and do better next time, and repeating it, that's how you learn. And I think this is not something you teach to medical students early on. They are not yet ready because it takes a lot of medical knowledge, nursing knowledge, before you can feel confident enough to share options. So I suggest to you that you let people qualify, get their knowledge, and then you say, now we are going to help you communicate well with patients in the real world. So I think this is toward the late years of medical school as you begin to see patients in real life. You can add this skill on. What you can do, though, in medical school is get the ethical principles right. Respect people, develop their agency and autonomy, communicate well. You can do that in medical school. But this added skill of involving patients, probably towards the late few years of medical school. Okay, quickly now. Who benefits from this process? I'm going to go pretty quickly here. I think we already know that patients benefit significantly. There is no doubt about that. People who do this know that their patients feel much happier, more satisfied, right? And that's important. We know already from many trials that the knowledge that patients have about risk and about their treatment options increases. That's pretty obvious, actually, if you give them good information. They will remember some of it, for sure. Not all of it, but some of it. So we know that. We especially know that if you use brief tools that are well designed. Comparison tables like option grids are just one way of doing that. There are many, many ways of doing that. Providing people with these information provides immunity against regret. If people know that bad things might happen, probability is low, but it might happen. When bad things happen, they say, oh, okay, I kind of expected this because you already told me about it. So they don't feel so angry or upset. They don't have as much regret. And that's really important because if people realize that bad things might happen, they don't complain. You already told them. So there are less complaints and less lawyers. Giving good information also increases trust and reduces anxiety. There are improved outcomes, particularly for people who have long-term illness, like asthma, irritable bowel disease, angina, and so on. Sharing decisions with them and helping them self-manage when appropriate really improves the outcomes, both at individual level and population levels. In some situations where there's over-treatment, overuse of operations, and this is pretty common in systems like the US, which pay surgeons for doing surgery, doing shared decision-making can reduce the amount of surgery. Patients say, well, I think I'll wait. I'm not quite that bad yet, I may wait. Or, I'll do something else. Instead of having a new knee right now, I'll try reducing my weight or increasing my exercise. So it can reduce cost in some situations, not all. But I don't think we should argue for shared decision-making on the basis that it will reduce cost. That's not a great argument. Patients will not agree with us to say, we're doing this because we want to reduce the cost. That's not a good argument. But for some people, managing cost is very important, as you can imagine. I've already mentioned this lower litigation. And so some health systems, particularly the US, I'm not sure about North Korea, this is a big deal. If people are more informed, they complain less, and you have less legal settlements, which cost a lot of money for health systems on the insurance side. I heard already about South Korea that the number of medical disputes is quite large. I think that this approach might reduce the amount of medical disputes. Okay, who else benefits? I've mentioned this a few times now, but this is, I think, an important issue because it has only really recently emerged that other people benefit. This study is about doctors. Doctors benefit by doing shared decision-making. So let me take you through the study. I interviewed last year 24 doctors who were champions of shared decision-making. They had really taken it on board. They say, I do this, I teach it, I embrace this approach. There were 14 males, 10 females. Most of them were practicing for many years, about 10 years. So they were not junior doctors, they were experienced doctors. They were seeing patients. They were not academics like me who just do research. They were really seeing patients, right? They were in many countries. Sadly, only one from Asia. She was from Taiwan. But they were from many countries. And as you can see here, they were in many specialties. They were not all family doctors who have a kind of real sympathy for this approach. They were from all different specialties, right? So what are the results? Well, there was not one person who disagreed with these results. They all said this. They felt better as clinicians. They were more professionally fulfilled and had well-being. They had a lower risk of moral injury. And the ethicists in the room will know about this. Moral injury is something that when soldiers come home from war, they feel bad about what's just happened. It's PTSD, post-traumatic stress disorder. And healthcare workers have this too. What it leads to is burnout. And most health systems have real problems with health professionals who have burnout. It's a significant problem. People go off work, maybe they drink too much alcohol, they get depressed, they get into conflict with their colleagues. I'm sure you know about this. They said, these 24 doctors said, you know, by doing shared decision-making, I feel better as a clinician. They also felt that they involved their team in doing shared decision-making, and there was better teamwork. We are on the same page. We have less conflict about what we're doing together as a team. So these are a summary of the results. They said that sharing a decision, whether to have an implant or extraction, reduced the responsibility on their shoulders. Oh, at least I know the patient took part in this decision, so I feel a little lighter. I feel a little less burdened. Because if something does not go well, at least I told the patients about that possibility. So the benefits, in summary then, we already know the patient benefits, right? They're very clear from the last 20 years of research. I think this is new data, and I think it's important data. Professionals also benefit. What I think the next step for us all as a research community is to show this, that organizations benefit. Organizations, the HR departments, the legal departments, the finance department, and so on. Report to policymakers, report to politicians, report to the government about the budgets. This is where this matters. Because if it's true that patients benefit, health professionals benefit, I think it's really logical that the organization will benefit in the long term. This is not an overnight phenomenon. It will take time. Not everybody will adopt this approach. But if more and more people adopt this approach, I think we might see health systems have better outcomes. Not just at the biomedical level, but at these other levels. Can we measure this? Well, I think so. I think we can begin to measure this. And actually, technology is helping us. I'm not going to ask you to answer these collaborate questions, but what we showed on Monday is that you can begin to measure how patients feel about shared decision-making. And we know that patients are incredibly generous to us, right? They really give us high scores on these measures. And when I asked people here to score, you gave them very low scores. Patients are much more generous, but we can find a signal. Some clinicians are much better at doing this than others, so we can find a signal. And if you aggregate at the department level, you can say, look, periodontology, I think is that the word, periodontology, is very good at doing this. Nephrology is very good at doing this. But those people over there, not so much. So we can begin to measure from the patient perspective. On the research side, there's a tool. There are more tools than this, but I developed this one, so I use this one, Observer Option 5. You listen to the recording, and then you ask humans to measure and score whether people are doing shared decision-making. It takes time. It takes a lot of training, and it takes a lot of time. So it's quite expensive, right? But you can also do it on educational workshops. These are the items, and they match very well to the 3-talk item. That's how they were developed, right? What we did recently is to say to a large language model, can you automate this? Can you just get the transcript? Here's the transcript of me speaking. Can you use the transcript and assess the degree to which those items are being spoken in the transcript? Do it automatically using these large language models. And we had a Pearson correlation of 0.7, which is pretty high, actually, with the human raters. And the large language models did it in minutes versus it took hours for humans to do it, right? So what is happening in healthcare systems, as you may know, in the United States in particular, and also other countries, is that medical visits are now being recorded. And then with the recording, the clinician gets a summary that is put in the computer. And they have to read the summary and say, is it correct? And they put it in the computer. So this is reducing the amount of time that you have to put things in by keyboard. That same transcript could be used to assess whether people are doing shared decision-making. It's not being used right now, but it has the potential to measure whether every single clinician is sharing information, is asking for preferences, is doing preference diagnosis or preference misdiagnosis. So there's a brave new world ahead of us. People are investing. The large healthcare systems in America are investing heavily in ambient recording because it saves the clinicians an enormous amount of time on their computers. But that digital transcript is like a gold mine for other work, for other data. So here's a measure that we are rolling out and trying out. It measures to what degree clinicians are willing to do shared decision-making. We ask them, should it be a priority for clinical care? Should it be is it welcomed by patients? Is it a good use of my time? Is it a skill I want to develop or maintain? Is it important even when the evidence strongly favors one option? I'm not going to ask you to score this now, but we are beginning to measure the attitude of clinicians towards this skill. And when you find a high willingness, you don't need to train. If you find low willingness, maybe there needs to be some investment. So this is something we are trying out. Some people here who look after people at the end of life might want to think about the considerate measure. It's a measure of attention to things like feelings, your plans, your will, and things like that. This is a measure of care coordination. When you have more than one disease, how well are other teams coordinating with you? These are short measures. My team really emphasized that we have to keep measures very short if they're going to be used by patients. And lastly, I want to just mention this work. It's by a colleague of mine called Ron Adner in Dartmouth. He's produced this book called The Wide Lens. I really like his approach, and I'm going to tell you why. He says that for any innovation, and I think shared decision-making is a bit of an innovation, it's new. Even though we've been talking about it for a few years, I think it's new. He says that when innovations come along, there's a risk of execution. Are we doing it well or not? But there's also a co-innovation risk. What else needs to happen to make this a success? And then there's this last line here called an adoption chain risk. Doing shared decision-making is not just on the shoulders of clinicians. We need people at health policy to say this is a good idea. We need organizations, the chief execs, to say this is a good idea. We need clinicians to say, oh, I'm willing to do it. And then we need patients to say, I'm willing to be part of it. And the problem with the adoption chain, which he points out in his book, is that any one of these chains says no, everything stops. Everything stops. And the most challenging part of this chain at the moment is the clinician here. They say, no, this is too difficult. We haven't got time. And they also say patients don't want it, by the way, which I don't think is true. So, I'm not going to go into great detail on this. I'm trying to write this up right now. But these are the co-innovation risks. We need attention to payments and structures and incentives. We need the patient information tools, the patient decision aids. We need more of them. We need the electronic health record to help us, and so on and so on. We need a lot of other innovations to support us. But this adoption chain risk, particularly clinician behavior and clinical educators, that's a key step on the adoption chain that we need to think about. Because I think at the moment it's stopping there. In many policy levels, people say, you know, we should think about this. It's a good idea. And healthcare system leaders probably say we want patient-centeredness. So they're not against it. But we need more support to move this chain along. Okay, I have been talking for 50 minutes. I'm sorry if I have been boring you. But these are my thoughts about shared decision-making. I think it's an ethical principle. I think it's a process of bringing democracy into healthcare. And I think we may face pressure from our patients, from the population, to do this sooner than later. This is the book I mentioned. If you want to get in touch with me, here are my details. Happy to answer any questions you might have. Thank you very much.
Thank you for the lecture. 지금부터 질의응답 시간을 갖도록 하겠습니다. 질문 있으신 분들 손 들어주시면 되고요. 손 들어주시면 저희가 마이크 전달 드리겠습니다. 질문하실 때 소속과 성함 그리고 질문 간단히 부탁드리겠습니다.
Yes, you have a question. You're from Communication Studies, I think.
Right.
I don't remember your name.
Yes. And thank you for Glyn for this interesting and fantastic lecture.
Thank you.
I have two questions for you. And
Sure.
first one is 죄송합니다. 안녕하세요. 네, 제가 너무 제가 너무 신이 나서 소속 말씀드리는 것도 깜빡했네요. I'm so sorry because I forgot to introduce myself.
Sure.
Yes. 저는 이혜선이라고 하고요. 커뮤니케이션 학에서 박사학위를 받았습니다. 그리고 이제 3월 15일부터 한림대학교 연구교수로 가게 됐고요. 그전에는 국립암센터에서 이제 박사호 연구원으로 근무를 했었습니다. Well, first one is there any or some limitation or criteria for better or well explanation for patient? Because, as you know, I participated in our previous exercise in Monday, but it was really interesting and it was a little bit surprise for me because I needed so much time to understand or decide for preferred options or my preference. And to be honest, I couldn't decide my preference or I couldn't make my decision for that exercise. So yes, my first question was that. And second one is, thank you for your introduction about some tools to measure SDM. But in my opinion, they seems like the most of quantitative approach. Yes. So do you have some qualitative approach to measure SDM or patient satisfaction? Yes. Thank you.
Thank you. On your first question, your experience of feeling, you wanted more time to understand and you wanted more time to form your preferences. That's a very common experience, And Professor Yu here has organized at least 4 projects so far where they are experimenting with different tools and different approaches to shared decision-making. What I think I'm noticing and observing in the projects here in South Korea and other projects in other parts of the world is that this is exactly right. When patients are given more information about choices, they first of all say, I didn't realize that there were many choices, very good choices. And then they say, I feel a bit uncertain now because I'm not sure. This is all very new to me and I need to talk to other people. And so what I see happening here in South Korea, because of the shortage of time in most medical visits, is that they are building tools to take some of this information exchange, the sharing of information. They are taking it outside the visit and before the visit. So if we have a diagnosis, we say, okay, you have now severe kidney disease. We have choices. We have hemodialysis or peritoneal dialysis. You can have a bag in your tummy, or you can have a hook up to the machine in the hospital. All those, the two ways of doing dialysis, pretty complicated. And actually, patients and their families need time to understand the difference. Which one is going to work for this patient, yes or no? So they've taken that into a leaflet, maybe a video, maybe a chatbot, and they inform the patient before, right? And it may take for some people 10 minutes to understand, but other people, if they're talking to their family, may take them half an hour or more. So you can move the option talk outside the visit to prepare people. And that's an important step. But then you take the informed patient and family back into the visit and say, do you have any more questions? What do you understand? Do you have any more questions? Or what is your preference now? And there starts another discussion. But that process of understanding makes this second visit much faster because you're already in a good place of understanding, right? So overall, the process takes more time, but you've done a lot of the work outside the visit. What that process I've just described doesn't do is to do the team talk bit. What are your goals? And when we saw the nephrologist, who I think I'll be meeting this afternoon, the woman was a young woman. She had renal kidney disease. And she was trying to decide whether or not to have hemodialysis in the hospital or the peritoneal bag, which she needed to change at home 4 times a day. But she was working. She was still at work. And so hemodialysis, where you spend up to 12 hours, 3 times a week in the hospital, didn't suit her. It would mean she had to stop working. So she wanted to know much more about peritoneal dialysis. And she ended the visit by saying, I want to talk to my family and I'll come back to you. So her goals of wanting to carry on working really mattered for the decision. But I could see in that visit, which was a 16-minute video, that we were heading towards a very good decision for this patient. She was better informed, she had discussed it with her family, and everybody was going to be satisfied, right? That this was a very wise decision. So that's what I'm describing. And your experience of feeling, oh, I'm overwhelmed or I'm confused is very common, and it's normal. But we need to work through that and help you, support you. What was the second question?
Well, there was
measuring, qualitative.
Yes, qualitative approach to measure, yes.
Yeah, I know. I think it's possible to ask patients and interview them. Did that feel good? But it takes time. And what people want is data, right? They want data, especially if you are going to reimburse or pay people. They want numbers and they want data. So qualitative interviews, very valuable. I do it. That's what my study was all about, right? Very valuable to understand something. But if you want to measure, especially pay for something, you need data. And it usually means numbers. Other questions? Yeah.
Thank you for your lecture. I'd like to introduce myself. My name is Jung-Sung Lee from Yonsei University College of Dentistry. The shared decision making is on the assumption that doctors are neutral for all treatment options, but Yes, we believe that all doctors and dentists have their preferences, and words of the doctors use and their nuances affect significantly affect the decision. So I'd like to ask you your opinion. Should it be also respected as the variety in the real world, or should it be controlled?
Sure. So this is about whether the clinician's preference or view should be influential or not, right? Yeah. There is no way around it, actually, right? You as a clinician may have a strong view about what's the right thing to do, right? Absolutely. And in some situations, that strong view is stronger than others. Let's take the view of vaccination for children, right? In that situation, I am not going to give a decision aid that says, it's okay not to have a vaccination for your child, or it's your choice whether or not you vaccinate your child. In that situation, there's no balance, in my view. There's a public health emphasis on, it's a great idea to vaccinate your child. In fact, we want as many children vaccinated for mumps and rubella and measles as possible. So in that situation, there's no equipoise, there's no balance, right? So in that situation, clinicians are correct to say, here's what we recommend. I'm not going to force it on you because you have choice. If you don't want a vaccination as a parent, you have your choice. But my recommendation is vaccination. So that's a very strong example, right? In Isabel's example, there were reasonable choices, right? And maybe the clinician has a more skill in myomectomy versus radio frequency ablation. Maybe. But I think it's right for them to offer the choice to the patient if those treatment options are available in the hospital. But in real life, we know that clinicians influence the decision. But I don't think it's right for them to influence the decision towards hysterectomy when the preference of Isabel was to have a future pregnancy. So there's a big difference, right? So we need to have reasonable options on the table. And if the patient says, I think this is the right thing for me, I think we should listen to them, where that is a reasonable possibility. And I think clinicians will vary here how strongly they feel, oh, I don't like the patient choosing that. It will vary. But the respect for the patient preferences is a gray area. But even moving slightly towards a patient preference is progress in my view, right? It's a gray area. Next question.
Hello, my name is Jiyeon Che. I'm in the Yonsei University College of Medicine, and my question is, I often interview doctors who do SDM, but some of them thinks the simply giving the option to patient to mean they are doing SDM. I'm worried about them. The SDM is becoming just a mechanical checklist.
Yeah.
Yeah. So of course, clinician is very busy. So we must be make SDM simple for them. But, I have a question for you.
Mm-hmm.
Did you also see this problem in your recently interview study?
Yes. Not in these interviews, because these people were real experts, right? They were good. People who are new to this idea often push all the responsibility onto the patient. I give you information about 3 things. Now it's your choice. You alone. I'm not going to help you. That's not helpful. Patients really don't like that. And they are right, actually. That is about abandoning patients to make a tough decision alone. That's not what I'm saying. What I am saying, though, is that if Minji here says to me, I'm still confused, I'm still not ready to make a decision on my own, I will try to figure out, okay, what's really important to you? What are your goals? What really is important to you about this decision? And I will say something like this. So, because I now understand you a little better, I think I know something about your preferences, I think the right decision is this one. Do you agree with me? Or do you have a different view? And by doing that, I think I'm more likely to check or to understand whether this is in the same line as what she's thinking, if she's not willing to express immediately her preference. So guiding patients is okay, but try to guide them after you've understood their goals and after you have understood their preferences, right? So abandoning patients like, it's all on you, not a great way, not a great way. And it is a problem in other places, yes. Because people who do that haven't really understood the idea, right? There's a question there and over here. Thank you. Yeah. We will come to you.
Thank you for the wonderful lecture. I'm Shin-Hye Yu from Seoul National University Hospital, and I'm a palliative care doctor in my institution. So, as you know, the shared decision making is really key concept of palliative care, and I have tried to doing the the shared decision making with my teammate and with my patient and families. So I have two questions. So first, in Korea, many patients find it very hard to talk about their values or preference. I think many Korean doctors haven't asked them about this question, or maybe it's because of a cultural factor, but it's very unfamiliar question for the patient, and they sometimes ask me again, like, goal? What do you mean the goal? Like that? So how can you help this patient share their values more easily during the SDM? That's my first question. And the second one, the clinicians often meet patients who cannot speak for themselves. So like those with brain damage. And in this case, we try to ask the family about the patient value and wishes. So how can you use the shared decision making with the family so they can make decisions for the patient, not for themselves? Thank you.
Yeah. You're absolutely right. Asking a patient to tell you about their values or their preferences is very abstract, right? And they are not used to being asked that question. So I understand. It's not very different in other countries, by the way. So I think you have to go at it a slightly different way to say, can I understand more about you? Tell me what makes you happy. Tell me what makes you sad. Tell me about who is in your family. Imagine if we go forward with treatment and it has a lot of side effects. Is that something you're willing to tolerate? Are you the kind of person who wants to avoid nausea or feeling sick? Or are you willing to tolerate a bit of nausea in order to have this treatment? So I think you have to paint a picture of the different possible outcomes. And then you have to say, if you had a choice, would you prefer this or this? Because asking them in the abstract about a value or a preference is too difficult, right? So you have to paint a picture of what the next few weeks in palliative care looks like. I have a colleague from Harvard, Angelo Volandes, who made videos, and maybe you know them, you do know them, who made pictures about what is it like to have comfort care versus more aggressive care. And the videos are beautiful because they demonstrate to the patient what it might be like to have different ways of caring. And the patients were very clear. Given a choice, I prefer this. So we have the technology to imagine the future. Future A versus future B. So I agree with you. Asking patients to tell you their preferences is not easy, especially if they're not used to it. So the second question about people who've lost their decisional capacity. It's a very difficult question. It happens in dementia. It happens when people have delirium or are very ill or drowsy. And yes, then in that situation, you need to rely on a proxy, somebody in the family. But as you well know, family members don't always agree with one another. So it's very complicated. So where a patient has made a plan for the future, an advanced care plan, you can maybe rely on that. But I think it's really quite important, and maybe I could go back to that considerate measure, to say to the patient as they come into palliative care, if things don't go well and you're not able to make a decision, which way do you want things to go? If it's too late to ask that question, then you are reliant on a good family member who you trust to act in the patient's interest. But that's not an easy thing to figure out, right? And it's an individual case-by-case basis. And sometimes hospitals where there's conflict in the family rely on an ethics committee. I don't know, do you have an ethics committee here?
Yes.
Yeah, and I think that's the last way, right? If we have real conflict about what's in the best interest of this patient. You had a question here, I think. Yeah.
Hi, thank you for your lecture. And my name is Moonhee Choi from Seoul National University.
Mm-hmm.
I major in sociology, so
Okay.
maybe a different view on your lecture.
Yeah.
Yeah, I'm actually involved in the SDM research team with the Professor Yu, and actually doing the interview with the patient and doctors
Okay.
as a pair.
Okay.
Yeah. So the thing is that the Korean patients are more likely to think that getting treatment is their right rather than as a choice.
Okay.
So, we have a well-developed health national insurance
Yes.
and the well-equipped the technology.
Yeah.
So the main goal of a patient is getting the best treatment.
Okay.
So they have a big belief in this kind of a system.
Yeah.
And the doctors.
Sure.
So I think considering this kind of different assumption and system, patients think it's their right
Sure.
rather than choice.
Sure.
So they don't like actually this kind of a choice talk.
Mm-hmm.
So they want to share their choice or preference with the doctor because it's, within themselves, it's within their family or friends.
Mm-hmm.
So they have something to think about, their decision,
Mm-hmm.
their preference,
Mm-hmm.
What's the risk.
Mm-hmm.
So make some decision within their network.
Sure.
And then, they talk with the doctor.
Mm-hmm.
So what's actually happening in clinic dialogue is that it's more like, I think the option talk in your theory talk model is the most clearly visible.
Mm-hmm. Yeah,
But we cannot recognize, we cannot see the team talk, which is the first talk, and the third decision-making talk.
Yeah.
It's kind of invisible and it's under the water.
Sure.
That's what we learned from, our interview.
Yeah.
So what if patients think that it's their right as well, rather than choice. They don't like this kind of, the probing their preference, thinking about their preference. They have a preference. They want to include their preference into their decision, but not shareable with the physician, not shareable with, maybe the hospital, something like that. So we can see there is some separation between patients and physician. Yeah. So, yeah.
I understand.
Now let me make it briefly. So
let me go to this example where we saw the nephrologist talk to a 30, 35-year-old woman, all right? She wants the best treatment too. She wants treatment for her kidney disease. Absolutely. But the right choice for her may be different to the right choice for somebody who is 65, right? So what shared decision-making does, I think, is to say, there are two very reasonable, good choices here. One is to have dialysis using a machine where you hook up for 12 hours, 3 times a week. The other where you put fluid in your abdomen and you change the bag every few hours. Both of them are successful. They're good treatments. Both of them are good. But which one suits you best? And I think that's a good choice to give to people, because if I was working, I would want the peritoneal dialysis because it's more flexible for me, right?
yeah.
The dialysis, I have to go to hospital, sit there for 12 hours, 3 times a week. That's not good for me. That's the kind of choice I'm talking about.
I understand what you're saying, but from our interview experience, it seems that that's kind of a doctor's point of view, like,
No.
What I'm saying, no. What I'm saying is that in patients' terms,
Yeah.
they are, both of them are talking about occupation in getting particular treatment.
Sure.
But doctors are more focusing on, with this treatment A, you will do both of work and treatment at the same time.
Sure.
But in terms of a patient's, perspective and point of view, they have many detailed and different narratives.
Maybe.
The patient's narrative is not translatable to doctors. So that's why they don't talk with the physician.
Sure.
So,
I don't agree with you. I don't
yeah,
agree with you,
yeah.
actually. I completely disagree with you because I think it's possible for the clinician to understand the patient's narrative.
The thing is that, that's actually another question. Like, you mentioned about the medical, the diagnosis,
Sure.
and actually the interesting was the preference diagnosis, right?
Yeah.
Do you think doctors, maybe in Korean, limited into Korean context, do you think doctors can differentiate between, medical diagnosis and preference diagnosis?
That's why I'm here.
Yeah. So the thing is that it seems that we met some doctor
Sure.
without understanding about SDM.
Sure.
We also met some doctor
Sure.
who are very
Sure.
well know about the SDM.
Sure.
Yeah, they looks very same. But the different thing is that the doctor knowing very well about SDM is, they are trying to make a lot of effort to differentiate between medical diagnosis and preference diagnosis. So without particular effort, they cannot include the preference diagnosis into their clinical dialogue. So
It would be great to talk more with you, but I have the view that a good medical diagnosis also includes a preference diagnosis. A medical diagnosis of renal failure is not complete until I have understood what is good for this patient in the future. So I think it's both. You have a medical diagnosis and you should have a preference diagnosis. And a good clinician will do both. That's my view. Now, I don't think it's easy. And I think many patients struggle with it. Absolutely. Really, many patients struggle with it. I agree with you on that. I agree with you on that. But I think that in the future, as people become more ready to understand from all the new tools we have, the choices they may have, they will want a good treatment. Absolutely, the best treatment. But it may involve both the medical diagnosis and the preference diagnosis. We can talk more, but I like your pushback. I like your pushback very much. So it's 11:20. What do people think? Is it time for coffee or cake? What do you think?
Yeah, it would be okay, but I think there are many
questions?
need to be
Yeah. I'm happy to
you.
answer questions.
Okay.
Yeah. Any more questions? Yeah, please.
Thank you for your lecture. And my name is Jiang Li. I'm postdoctoral researcher in Seoul National University College of Nursing. I can learn about shared decision making more deeply, and I know that healthcare provider skill is very important for shared decision making. And my question is, what are the required capabilities and roles of patients in shared decision making, do you think?
Okay. Right. I don't think it's really fair to ask patients to have new skills. No. Patients come in all sorts of sizes, right? They come in all sorts of levels of education, all sorts of levels of health literacy. I think this should be adapted for every kind of patient, whether you're poor, whether you understand the language, whether you're from a very educated background. It doesn't matter. Who should change is the clinician. The clinician should be flexible. Oh, so you really have not had much education. You don't read very well. So I have to provide you with information in a way that's easy for you to understand. And so there are limits sometimes to how much data people can remember or take in. So we have to be very, very flexible about, in some situations, we can try to get people to understand better. But there are limits, right? We only have a certain amount of data, we only have a certain amount of time. So my feeling is that, let me backtrack a little bit. If you use patient decision aids that are really well designed, the people who benefit most from these are people who have low health literacy. People who are not reading the newspapers or not searching the internet. They are usually have low education. But giving them more understanding, they say, oh, I did not realize that there were choices, first of all, choice awareness. Second thing is, I did not realize that this one has this harm and this benefit. And I did not realize that this one has this harm and benefit. And I did not realize that this one is much better for me. Given I have no transport, no money, I cannot go backwards and forwards to the hospital many times. I just can't. So for me, this one is better. So I don't think we should ask patients to change very much. We should adapt and support them, which is where I mention non-abandonment, right? And making these decision tools really well designed for people. It doesn't mean that we have asked people to read. We can give them in video. We can give them in animations or cartoons. It will cost us money to make those tools, but we can do it. Does that answer your question a little? Oh,
yes. And then what is the things that a patient can ready to engage in shared decision making?
Well, I guess it's being willing. So when Dr. Lee asked them to look at the cards, to say, here's the news for this treatment or this treatment, to be willing to say, okay, I'll take a look. That's all we ask, really, to be willing to maybe take part in the process, right? But even if they say no, today, we can be gentle and be kind and say, it's okay, we can help you. Next time, maybe they say, oh, okay. Because now they trust Dr. Lee a little bit more, because he really helped them, right? And now they trust him. And if Dr. Lee says, let me give you some information about these choices, okay, I will try. So it's a process of developing a relationship with people, even though they feel at first a little bit uncomfortable to take on the responsibility. When I was being taught how to be a doctor, somebody told me, you will end up looking after the patients you deserve. In other words, I am educating patients during my career to respect the way I work, right? You end up with the patients you deserve. Other questions? Yeah. Yuri.
Thank you for your wonderful lecture. I'm the postdoctoral researcher at the Hanyang University. I want to kind of add on to her question a little bit. So, you mentioned that you emphasize the physician's role in shared decision making. So I was wondering whether you would try the different strategies for, depending on the population characteristics. Like if you compare older adults and the younger population, they might have different cognitive abilities and different health literacies, right? Mm-hmm. So whether you have tried like different strategies that educating to the physicians or just apply the same.
Yeah, that's a very interesting question. I mean, diseases come with certain population characteristics, right? This disease happens in younger people, or this disease happens in younger people. Depression happens to cross many ages and many health literacies. So from that point of view, I don't know of many studies, for example, in depression, where there's a wide age spectrum or a wide spectrum of educational capacity, where people have tried really very different tools at the same time. What we know is that making, do you know about the universality, oh gosh, I can't say the word, universal principle, so that you make tools that are really suitable for people at a reasonably low level of education. And because if you do that, even people at higher level of education can use those tools. But you make them so that they can be universally used. The people with a high level of education may want more information. Yeah, of course. But they can find it pretty quickly because they know how to do that. But the people who had a low level of literacy, that's where you start. You assume low level of reading age. And what we tend to do is a reading age of 12 years. That's where I think it's possible to make text-based tools. What we haven't really studied at all is how low in literacy can you go with videos or cartoons or animations? Because they cost a bit more to do, right? But so interesting now that we have large language models where you can make an animation pretty quickly. And you can ask the large language models to say, I want it to be possible for a person with very low literacy to understand this and make a picture people can understand quickly. So suddenly, over the last 2 years, we have tools that quickly can make more versions of different tools. I think we have to be very careful with that because we need the science, the data, the facts to be okay, right? But the ability to make a pretty reasonable tool for low literacy people is with us now. So I imagine there's so much research going to happen about how to use large language models to make new tools for patient understanding. It's just started, actually. Yeah, just started. In fact, one of the projects.
I'm so sorry, but we should wrap it up.
We should wrap it up. I just finished. One of the projects here that Professor Yu is helping to lead, they're using a chatbot in ankylosing spondylitis and rheumatoid arthritis, right? So the chatbot asked the patient and the chatbot to have a conversation outside the visit. So such an interesting tool. I haven't seen it working, but I hear good things about it. And that was a very nice project. All right. So thank you so much for your questions. It's time to have a break. Is that right? Finish. Okay, great. We are done. Thank you so much for your time.